Hello, everyone. We are back. And by we, I mean both me and Dr. Jill Crista, who she needs a trophy of some kind. The most had guest on the show in the history of all the years. So I'm excited to have Dr. Jill back again. Hey, what's going on?
Nice to see you. It's been a while.
I know
My trophy needs to be the 50, like I get to come every 50.
it's every 50. Yeah, it's correct. This is episode 200, by the way, everyone listening. And so
Right.
Jill's been on number 50, number 100, number 150, and then 51, 52, 53. I think we did like
Oh,
four
right, right,
right
right.
there. And then 200. So this is a thing. Awesome. So I'm so glad over the years that we still get to chat. It's been a long time. So it's nice.
I know it has been a while. Too long,
Mhm.
for sure. Yeah.
I remember when I first met you was at the TFIM conference in Seattle or Washington, wherever it was. And it was the first time we met. And you showed me your book. I think it was pretty new around then. It had just come out or it was recent.
Mhm.
And you went to the back and you had We Inspected My Name in the back and the references. And we had never met before. And I was just like, that's so
Like,
cool.
wow. Yeah.
So cool. So,
Well, I,
um,
of course, was already a Levy fan. So, it was by proxy. You got
it's
that.
true. It's true. You marry into the clan and you're there. Yeah. Um, well, cool. So I'm glad that we're doing this today. So the plan here is to make this a tight, like very concise episode on a specific concept that we were just talking about before we started recording here, and to kind of give views on both sides of the coin on certain things and maybe some examples of situations we've seen and stuff like that. So here's the setup. So I mean, by the time this episode comes out, some time will have passed. But over the last month or so, both me and Corey, so co-founder Corey Levy, one of the Levy clan, I just married in. I wasn't lucky enough to be born in. I married in. Um, so we've actually been circulating ourselves throughout the interior operations of We Inspect at all phases, from taking the calls initially when someone just calls in and is like, hey, I might be concerned about something, all the way through to the back end where we're actually doing the consulting on the back end with the client once the results come in and all of that stuff. Because we just want to see it all and make sure that it's still running the way we want it to, but then also to see if there's been any changes or shifts just generally in what people are thinking or where their heads are at or what's going on. And I'm really glad we did that, because something that we kind of discovered more so in the front end conversations when someone calls initially, was kind of a different conversation as opposed to maybe over the last like couple years leading up to now. And it's really actually rooted in an uncategorized fear, kind of, in a way, if that's the best way to say it. So we'll be talking to someone and we're talking to, what's going on with you, what's happening, tell me about, kind of just doing all this stuff to figure out, what the situation is and how, everything would work. And it gets to the point where inevitably every time, I'll ask, I'm like, hey, does this process sound like, what you're looking for, right? And every time it's yes. Yes, this process sounds great. Okay, cool. Um, so then we start talking about, okay, so let's, do you want to, move forward and do an inspection? Like, does that make sense? Now they walk through the process and they're like, well, yeah, I mean, I would love to, but I'm concerned about, it's not the inspection piece of it, actually. It's about what happens after the inspection, meaning what you explain me this process, it sounds great. I'm pretty confident you're going to find, things because of what you just described to me. And and then what do I do? Do I have to rip my entire house apart because you found the things, right? And it becomes this actually like future paced fear of something that hasn't even happened yet. And because of that, people I've been seeing are like, they become really hesitant, they become limited. There's a fear around it. And I think it's tied, current economic climate and things are tight. And like, I think that's kind of what's driving it now as opposed to maybe 2 years ago. And so that's what I want to kind of talk through, like throughout this conversation, is this lack of movement towards progression because of a fear of something that might happen. or maybe might happen. And so my thought was if we could talk about the worst case scenario and then maybe dial back from there, like, well, if you approach it a different way or a different way, it could still be beneficial. Then maybe people listening to this could be like, oh, I feel a little more comfortable like with this now. So that was my thought. Does that make sense?
Yeah. Yeah. And from what I see, and I shared this with you before we started recording, I do peer-to-peer consultations. I'm the second opinion. And these very smart, great doctors who have wonderful plans, the plan isn't working. And so it's like, let's get a second opinion. And when they meet with me, probably 80 to 85% of those consults, the patient has convinced the doctor they're no longer in mold, and they are still in mold. Because there's certain lab tests that we can do that we can point more arrows to the fact that it's like, yeah, that's still an active exposure. And that's really problematic because I know, it's funny you said two sides of the same coin. It's funny you said coin because it's the economics, and it's fear also of your sanctuary getting blown up, basically, losing things you're attached to, all of these fears. Because if you go in a support group, you're going to hear the worst case scenario, of course.
Yeah.
And but it is economic. And when we just step back to say, how much did you spend on that doctor visit? Not that I'm trying to put doctors out of business, but how much you spent on that doctor visit? How much you spent on your lab testing? How much were supplements? How much was medication? Did you meet your deductible on your insurance on some of these things? Just all of these costs. And from my experience, about half the people, when they get out of the exposure, they're better. Their body just resets because it didn't get as much impact from the mold. And so, I just really, you'd be much better spending the money on the building part and get that taken care of because these things can smolder. And I think when we were talking earlier too, it was sort of like, what do you do about the people that are willing to do just one part of the remediation, but really it would be better for them to do all 5 things that you found or whatever. And I always talk with patients, it's kind of like smoking, if you go from, it's this fallacy idea that we have. If you go from, a pack of cigarettes a day to only 3 cigarettes a day, medicine will still tell that smoker they're a failure because they didn't quit all the way. But what I see is you just reduced your total cigarette count every day,
Yes.
and that makes a difference. That makes a difference on the total load. And it's an important thing to take that action, even if it is just 1 less cigarette a day. We need to celebrate that reduction. And I see that same thing with mold. Like whatever you can do to debulk the problem in your environment, you are going to save medical costs and you're going to save from some smoldering problem down the road because it always breaks my heart. 4 years later, we get a child with lymphoma. We get a elderly person that develops dementia. We get cancer diagnoses. We get kidney disease that's non-recoverable. There are these smoldering things, MS. And then the person, thinks, well, I'm just unlucky. And, for me, with my mold experience, it's like, no, that was not taking care of the problem in your space. So do something. Get rid of those cigarettes one at a time, so to speak, your mold problem as you can.
That's a really good analogy. You know me, big sucker for
I
analogies.
know, we're very
I know. I use well, you took it from Dr. Cranium, but I use the solution, pollution, solution all the time. I actually just said it
that's
to
a pretty end.
somebody. I said it to someone yesterday and I credited you, then subcredited original. Like I do it
Yeah.
every time I say it. It's so funny. It's
I
like
do the same thing with you with Mold Factory and the smoke. I'm like, this is all credit to Brian Carr because this is great.
Well, I think what you just shared is really, really important because I have seen similar feedback from clients as well, right? So we've actually reshaped how we present information to people around this concept to help alleviate the fear of I have to do everything or it's so overwhelming. And so, sure, here's your labs, here's how to fix every single thing, but then we kind of overlay like, let's say there's 10 things, these 4, these 5, that whatever they are, these are the ones that we're tiering in like top group tier A as the ones that we think have the biggest impact on exposure, right? And so to get to your point, is if you can reduce the exposure as much as you can, right? So you're smoking a pack of cigarettes, you turn it to half a pack of cigarettes, you turn it to whatever, right? Well,
Mhm.
what's interesting is then say you have a full pack of cigarettes, that's 10 cigarettes. Let's say that 3 of those cigarettes or 4 of those cigarettes have double the nicotine and cancer-causing stuff in them that the other
Right.
6 do. So now if I'm looking at the 10, I'm not just equally picking one of the 10, but I'm saying these 4 cigarettes, if I could cut these 4 cigarettes out, I'm actually reducing the impact on me maybe instead of 40% by 60% or 70% because they have more of the load in it. And that's like the view that we're taking with how we're showing what's going on, right? And so it's really interesting to hear your side of it as well, because I think that there's a correlation on both sides that sometimes people just don't put the pieces together. And neither of us, and you can correct me if I'm wrong, are saying like it's okay not to remediate things you're exposed to, right? Like ideally you
Right.
want it to be gone, right? But we live
Mhm.
in the real world. There's
Mhm.
circumstance, there's situations, and to go and tell somebody it's either all or nothing is just not a realistic way to live. And so, I've seen clients that have reported success and progress by taking this approach. And it sounds like you have seen similar types of things.
Yeah. Yeah. And I think the danger in that is that people that are trying to deny the problem can hear, oh, well, we only have to do this one thing and then we're done. Full stop. It's not a full stop. It's a step. It's a first step. And with some of the families I work with, they prioritize the removal. And then the rebuild takes a while. They need a few months more income to get the contractor in there or whatever. And that's fine. Living in a construction zone is not a health hazard. Living in mold is a health hazard. So even if what you can do is the removal part, can you be down one bathroom in your house for a while? Can you have someone come in and at least do the removal? And then it might take a while to do the rebuild, and that's a pain because you've got, to share the bathroom or whatever, but that's not a health hazard. That's a pain, but it's not destroying your health.
Yeah, it's a really good perspective. One other thing you said that I think sometimes people don't think about, actually, I know a lot of times people don't think about. You actually mentioned 2 health costs when you were describing it before. You mentioned the cost of the doctor visit, the supplements, the this, the that, all that stuff. And that's like your more immediate cost. That's like how you can compare like right now to right now. Remediation costs this, I'm paying this amount to go see doctors and supplements. But the second thing that you added on to there, really, there's not a value on that except of this is something that can significantly either derail my quality of life slash end my life at some point early. And those are those long-term things that compound when you have the issues that continue to happen. It's it's really hard, I think, for people to see that far in the future a lot of times when there's something short term that needs like a significant decision. And when you're doing like an analysis in your brain, there isn't a direct correlative analysis on something that may possibly happen 10 years down the road, as opposed to this costs this right now, and this is what I'm spending on the doctors right now. And
Mhm.
so, I just think it was a really good point that you brought up. And when you're talking about this, trying to balance out like a remediation might cost X, I mean, the first thing is how much are you spending currently, right, on your stuff? But then it's like that other cost. I mean, if you want to think money side, how much more money you're going to spend down the road, but even forget that, like the quality of life and the impact side is like in an immeasurable comparison. And I just think
Mhm.
it's a really interesting thing that you added into that.
Thanks. I'd be curious to know what are the things that you guys are looking at on the results or that's why a good inspection is so important because speciation is critical in making this assessment. What I'm looking at from the health side is what are the species that we're looking at and then the load. And if we have mycotoxin results, what are those? And that's why ideally I'm getting a spore speciation and load and also the toxin and the bacteria. And what I'm looking at from the medical research is there a trichothecene forming mold? Because that takes the cake, 100%.
Mhm.
Next, it is, what are the active ones? Because then we know we're getting both mycotoxin potential and the regular metabolic toxins like mycophenolic acid, which is a potent immune suppressant. So it's going to set you up for more problems, more chance of
Mhm.
colonization, more chance of, these are also carcinogenic. So which means can cause cancer. I always forget to just like use normal person language when I this, but like that's scary stuff, you know? And the
Yeah.
trichothecenes, the reason why those trichothecene formers get my attention and my priority. So if I'm seeing that, I'm like, just please take care of that issue, period. Then we'll talk about the rest of it. And the reason for that is that they're extremely potent.
Mhm.
So trichothecene mycotoxins, I'll throw out some numbers. Let's say it takes 100 aflatoxins to make you sick. Okay. Um, Trichothecenes, it takes one. That's how potent they are. They're like a 1 to 1,000, 1 to 100, 1 to 1,000, depending on which we're comparing it to. They can actually be lethal at at certain doses. And what we find is that in medicine, if you're exposed to a trichothecene and you're starting to have vomiting and diarrhea, those symptoms show up at 1/5 to 1/10 the lethal dose. So
Wow.
I tell my patient, I'm like,
Wow.
those are your symptoms, and we know that's in your house. Get out now. And that's high priority of what to put your attention on. So the potency of that mold, those molds, that's, Stachybotrys, Trichoderma, Wallemia, Chaetoglobicin, who am I
Mhm.
forgetting? You could probably rattle them too. But those
Yeah.
particular molds make, I have a fact sheet if anybody wants this information. Um, for whatever mycotoxin there is out there, you can go to my website, drkrista.com/ put in the toxin. So it could be aflatoxin, trichothecenes, MPA,
Cool.
gliotoxin, and there's a fact sheet, a symptom list, what I'm using with my patients to get rid of it. And because
Wow.
every mycotoxin gets out of the body in a different way. Not everyone goes through the liver. The majority of them actually go through the kidneys. And so in order to get them out of the kidneys, we need bioflavonoids, not binders. So it's really important also that you're targeting on your treatment. It will save you money, get you better faster. So I am so like, I don't know anybody who spends their weekend reading about Chaetoglobicin, but I do because this is my obsession. But yeah, I mean, like those trichothecenes, if that is anywhere in your environment, that's your priority, period. It makes it very easy.
That was so helpful. I learned like a lot in that little snippet that you did. That was amazing. Um, yeah, well, we'll get the links for that. People definitely need to see that stuff. I'm gonna go look at that stuff.
Yeah.
That's
And
amazing.
if you're a practitioner, I have like a big beefed out with all the metabolites and all of that. Very detailed technical sheet for each one that you get in my practitioner courses.
Very
So
cool.
you get more. Yeah, I just launched something called Updates in Mold Related Illness to catch everybody up to where I'm working. I'll try and do one of those once a year because there's just this whole industry is so untapped and unstudied, and we're learning a lot with our research study. Dr. Nathan and I have a study going. We're learning a
Yeah.
ton. Yeah.
How is
So
that going?
great. It's
Yeah.
great.
I know we
Yeah.
talked about it a little while ago. So
Yeah.
how far in the timing of the process are you with it? And can you
Uh,
tell out like generally what the study is?
yeah. So the study is it's the Mold IQ Research Initiative. So Mold Illness Questionnaire. That's at moldiq.org. And we're trying to first validate a symptom questionnaire to lab testing. So that's the first thing, and it's crowdsourced. So if you're listening, you want to contribute your data, please do. We need that. We need help with people contributing. You fill out a symptom questionnaire that I had been using in practice that has a scoring system. And we're trying to find out, is the questionnaire valid as a tool for diagnosis and measurement? And our first preliminary research, which we just presented this year at the TFIM conference, is that the questionnaire scoring does have a positive predictive value. So people can actually fill out the questionnaire and start to diagnose themselves. And that was the whole goal for me for, what we're talking about right now is the economics. If you cannot afford the lab testing, or if it's like, I could put the lab testing on toward my whole family to the remediation, I would much rather people do that because avoidance is the number one tool. Now, now that the questionnaire is valid, we're going to refine it and fine tune it and continue to get it to be a better questionnaire and shorter questionnaire. But now what we can do is we can use that tool to do interventional studies, which you already know from your experience, even inspecting, inspectors and remediators get the highest burden. And so if we can do a control group and then a treatment group, we can find out what is getting people better faster using remediators and inspectors. Because that's the problem with a toxin-based illness is we can't, the NIH, thankfully, medical ethics won't let us purposefully poison people so we can figure out what we need to do to get better. Because
that's fair.
the treatment is don't be exposed to the toxin,
Right.
But if you become the moldy building, you're becoming your own source of toxin. And so how do we get someone better, faster from the toxins?
Can we go into that again? We've talked about it before. I literally send out the snippet of the podcast that we did every time somebody asks me, how is there not mycotoxins in my house if there's mycotoxins in my body? And I always say, Dr. Jill had this awesome answer. Here's the snippet, send it to you. I mean, that was from like a year and a half ago or 2 years ago, whenever we recorded that. Can we refresh that now for people who haven't heard that? Because it's not uncommon. So you asked like what we look for, right? So let me do that and then we'll go into Yeah. So it's really similar, right? So the way that we prioritize is based off of mold type. And then we actually talk through a framework of multi-tier prioritizing. Some of it requires feedback from the client. So we do that in real time on the consults. And so what we provide in the initial is really just based off of the data, and it doesn't overlay any other information that they have. And then we kind of talk through it with them. So the first layer is all just number data driven, like what we're seeing. And so there's two pieces to it. One is if Stachybotrys, Chaetomium, or Fusarium are there, it's automatically.
That's who I forgot. Yes.
Yeah.
Thank you.
It's automatically top tier in tier 1. So you could have literally one spore of Stachy. If it's there, it goes into tier A, and for all the reasons that you said, right? The other thing, which is kind of important to share along with that, is if anyone's like poured water on a or dropped water on like a paper towel, like where you drop the water is the most wet, and then the water kind of like wicks to the drier parts, right? And so that's how water works, like wherever you put it, right? So your molds that require the most water are going to only grow in that area where the water is enough. As the water works a little further over, you now won't have Stachybotrys growing. You might have like species that need a little less water that can support that type of species to grow. And those are some of your Aspergillus, Penicillium, stuff like that. And then as the water goes further away from the source and it kind of spreads, it now has less moisture that's there because you're getting away from the source. And you get other mold types that can start growing that require even less amount of water. And then at that point, you get into just elevated humidity that was increased from the moisture in the first place. And you get other mold types that can grow because of just humidity, right? And so the reason I lay that out is because if we're picking up Stachy or Chaetomium or Fusarium or even some of the other high water those aren't the only ones, but if we're picking those up, then we know that there's enough moisture there for them to thrive, which means there's a chance, I should say, of a larger hidden issue beyond right where we test it, right? Yeah. And so that is why like those three are automatically topped in, and then because they have the really potent toxins that we talked about, they live there, right? So that's the first part of our tiering to put something into top tier. Then the rest of it is actually shaped around levels. And so we've built out internally like leveling tiers because we've seen so much, right? And so we'll say if something falls within this kind of like level, meaning spore count, like total concentration load of mold that's in the lab sample, then we will tier them based on that. And so that's how our tiering comes together on the front end. Now, after the fact, which is getting into what you were talking about a minute ago about correlating like health results to this and different things like that, that's where like the follow-up conversations come in once we do the consults on the back. And we'll be talking about it and say, hey, okay, just based on the raw numbers, let's say, I don't know, the laundry room is a tier A, let's just say, right? Um, the next question is, how does the most affected person in the house live in the house? And
Yeah.
so what we do is we create exposure zones as part of the conversation. So you have like a primary exposure zone, a secondary exposure zone, and then your tertiary kind of like third level exposure zone.
Nice.
Primary, yeah, the way that I think primary is like I spend more than 4 hours a day in that space, right?
Right.
So that becomes primary. Secondary is, 2 to 4, something like that, like secondary. That's generally like kitchen, living area, great rooms, maybe playrooms for kids, like stuff like that. Primary is obviously bedrooms and like some of those areas. And then third level, tertiary would be I don't really ever go in this room. Like my kid doesn't go in the laundry room. Like why would they go in there? So that's like a tertiary zone for them, right? And for that individual. The other layers to that are supplemental areas or systems in the house that impact those. So your HVAC system is going to continuously impact your primary exposure zone when it's on. So that becomes a primary tier exposure zone when we think about it.
Mhm.
If you're talking about an area, let's say on the downstairs and you have a crawl space, your crawl space is right connected to like the downstairs bedroom where your sick kid lives. The crawl space becomes ultimately like a primary contributor to that space, right? So that's like the second layer that we lay on is how do the systems of the house connect to either primary or secondary? And then we would lump those into whichever category they go into.
Yeah, that's beautiful. Yeah.
And then the last piece is then tying to what you were talking about. Okay, who's the sick one and what are they sick with, right? For lack of a better, you talking clinical and me talking are two very different things. And so, what's the toxins that we're looking at, right? And now what you can do is say, okay, if it's trichothecene and we know trichothecene is going to be, let's say, fusarium and stack. And frankly, if that's there, I'm going to lump cotomium in with it because they kind of grow together, right? So let's say that's the one that's in the body. So what we've done is we've now layered a 2 additional layer filtering system on top of the core foundational information, which is just the raw data from the lab. So in a perfect kind of formula, if we're thinking about it, I have a tier A, which is based strictly on the lab result number, right? And then I overlay how does the person live in the house as a primary, secondary, or tertiary area. And then I overlay, does this connect to the health issue that we're worried about, right? And so if I get a list that is tier A concentration number, tier A priority zone, and tier A, this is the toxin that's in my body, that becomes, the winner for lack of a better term of like, this is how you start prioritizing where you run at.
Right. And to bring it full circle, by getting that area out, you've just taken care of 9 out of 10 cigarettes, even though it's one area because of its severity and correlation. And yeah, right.
And this is the idea going back to the initial setup of why this is like why we, I don't want to say shouldn't because that's not the right word. Why understanding this can help alleviate some of the future paced fear of I have to gut my whole house, right?
Yeah.
Because just talking through what we just talked through, we now realize that you don't necessarily have to do it in that manner if you're really targeted and smart about the areas that you do go after.
Yeah.
So,
Yeah.
cool.
Precision. That's where we need to move to. It's precision in the inspection, which you guys have always done, precision in the remediation plan, and precision in the treatment. That's why I created all those fact sheets because I was like, we can do this better and faster. And if we are doing it better and faster and they're not getting better, we know there's a lot more work to do in the environment.
Exactly.
Mhm.
So let's transition to the last piece that we talked about. But I feel like we buttoned that. Listen, we did
Yeah,
that 25 minutes. I think we did
that's pretty good.
a really good job. Um, so I'm going to ask you the question again that I asked you however many years ago and you answered. So I would love to hear your new fresh take on it or if it's exactly the same and we'll see.
Might be.
I have mycotoxins in my body. They're not in the house. Side note, it's not uncommon for that. Like parentheses, it's not uncommon to not see the toxins in the house, just so everyone knows. It
Yes.
can be, but it's not always connected that way, right? Back to scenario. It's in my body. It's not in my house. Why is it in my body if it's not in my house?
Yeah.
Did the inspection fail and miss something that they were supposed to find?
Yeah. And it might not even be the inspection failed. It might be the mold isn't competing at the moment.
Mm-hmm.
So it could be just that the mold is quiet. That
Mm-hmm.
no one else is trying to move into its territory because mycotoxins are only made in a competitive environment. That's why I
Correct.
always tell people when they only find one mycotoxin in their body, there are more because they wouldn't have been made unless there was competition, which means the other mold is fighting back with its toxin. And
Mm-hmm.
I know that because when we retest people, we find more things. The original one comes down, and if we're doing a good job of helping with excretion, more things show up. But what happens is that over time, your respiratory passages, because these are immune toxic, it starts to reduce its immunity and its defense systems. And mold can literally move into you. And that's what we call colonization, which is a pretty controversial concept. You know, when I talk with EENT doctors and things, they would say that colonization doesn't necessarily need to be treated. Some of them say it doesn't even exist. But if we use the word biofilm instead, now we can have a conversation. But it's all the same thing. There's just
Mm-hmm.
degrees of severity. So what can happen is these spores, if we tested everybody's sinuses, and actually Dr. Joseph Brewer did in 2013, and this is when I was like, oh, okay, I'm missing sinuses. And I started putting my patients on nasal treatments and they got better much, much faster. So it was phenomenal to watch, actually. I would say like one of the steepest curves of improvement that I've ever seen. So what they tested is they had a control group and a sick group. Sick group was made sick from a water damaged building and they had chronic fatigue syndrome. Control group, sick group, both groups had fungus found in their sinuses when they took samples. The difference is the healthy people had absolutely no mycotoxins in their sinuses. Sick people did. And they tested lungs, gut, brain, found the same exact thing. Healthy people, no mycotoxins, sick people, mycotoxins. And that's when I realized, oh my goodness, when you're sick from mold, the mold we find in the nose isn't just something you happen to breathe in when you went on a walk and you're going to breathe it out and your snot is going to dissolve it. So it's just a passer through. If you're sick, that's become a resident. And what we find is those actually start to make mycotoxins. I work with a wonderful EENT in Atlanta, Georgia, Dr. Donald Dennis. He's a brilliant, amazing guy. I had sent him a Parkinson's patient because I'm like, I know this is from mold. And he had sinus swelling. It was just sort of like most EENTs would sort of shrug, like, oh, there's a little sinus thickening. Dr. Dennis, because he's so brilliant, he's like, that's a fungal ball. That's not like inconsequential. And this guy
Wow.
says it's a brain disease. Like, don't you think sinus brain, they're kind of
So
neighbors.
close.
Maybe
Yeah.
we should do a little investigation. So I had sent him to Dr. Dennis to have a assessment for sinus surgery because he was symptomatic with his sinuses, which does not actually have to be true. You can be pretty asymptomatic, kind of just have a little bit of maybe I have a deviated septum or, runny nose when I eat or something like that. And you can still have a fungal ball in there. Like this guy he had pretty significant sinus symptoms. It made sense for me to refer him. Dr. Dennis does surgery on him, pulls out a fungal ball, puts it on the sterile paper, and it continues to make mycotoxins out
Wow.
of the body.
Wow.
Isn't that wild?
Wow.
I was like, oh, whoa. When I say you become the moldy building, you really become the moldy building. Like you're walking around with it. And it can be, this was, I've had patients 20 years prior from a college building or, college housing, still sick. And then we get their nose taken care of and symptoms go away. It's profound.
Is it only the nose, or is it primarily the sinus nose area where the biofilm happens, or is it other places?
It's other places, but at that time I was already addressing the gut. So
Hmm.
I'm a naturopath, I have to do that. So yeah, I was
Yeah.
already doing like, treat the gut and address biofilm. But when I added the nasal treatment to that, so I kind of think of it as you need to do both and not ever one without the other because every time you swallow post nasal drip, you're seeding your gut.
Yes.
Yeah.
You, in the past, you didn't directly say that, but I like connected the dots, I think. And then I started telling people that. And because it made sense. just glad you said it. So,
Yeah, yeah.
so
I know it, I have it in my book and I say it much better there. And then I was like, why don't I just say it how I say it in my book? You're seeding your gut when you swallow. So, take
Mhm.
care of the sinuses really take it on because that's your first interface. And this is a respirable problem more than it is a gut problem. So, yeah.
Two questions. Um, one more, or I blanked on one, so I'll give you the other one.
All
Uh,
right.
I only wrote one down, and so now here I am. Um, you mentioned like, oh, you have a runny nose, you have this. If someone has like chronic sinusitis or they have like these things, is it a high likelihood that this is happening in there, or there are other things that can be doing that?
Sure. And there can be bacteria. We didn't even touch on the
Oh,
actinomycete and endotoxin situation, but
no.
actino's favorite food is chitin. Chitin is fungal cell wall. So you can have both problems, and the fungus actually is promoting and feeding the actinose problem. So you can have bacteria overgrowth in the nose, and that's all. You can have
Mhm.
fungal overgrowth, and that's all. Typically, we're going to see both. And if you have a bacterial thing that won't go away, like a MRSA, like a Marcons, like an actinose, they quite often fungus is what's behind it because it's more tenacious and it's smarter. Wild, huh?
It is, and but it's like so helpful to hear, right? Like, and to understand the connection. Oh, this is my other question. Um, I'd actually been talking about this with so other questions that I heard when I was on the front taking calls. What
Mm.
should I be testing my body first or should I be testing my home first?
Mm.
And it's a fair question when you're just asking it from a high level, like, oh, what do you do first? If I'm sick, I should test my body first, maybe, or whatever. My answer, well, sure. What's your answer? If you had to pick one, home or house or home or body?
It's always depends. It's always depends because it's far easier to find it in a building because we can take tissue samples, right? You can actually cut and find it. That is assuming there's someone looking at it like you
Mm-hmm.
and not a random air sample in the middle of a room person. So in the
Very fair.
body, it
Yeah.
can hide. And our testing in the body is wanting, we could say. So I find that a cluster of testing works better. Points,
Mhm.
because one data point is not sufficient in this complicated illness. Not at
Mhm.
all. But yeah, so it's a big fat depends.
Yeah. Well, so I agree with where your head is at. I mean, if the depends is, are we actually getting real house testing or are we getting, local guys somewhere, then maybe you go body first, right? But if you feel confident in the ability to figure out the house piece, here was my point of view, and it was really similar to what you just said. It's like the body is complicated.
Yes.
I mean, we don't even know how it all works yet, and we probably never will. And we know that mycotoxins can hide. We know that if someone is like really toxic and they can't detox, that you could do a urine mycotoxin test and see nothing,
Yep.
right?
All right. It's an
Flip
extreme.
side, flip side, if you detox great, you might see mycotoxins in your output, but maybe you actually don't have a huge load and you're just really detoxing super well. And so it's like, what do you make of that information? Which is why you're talking about cluster of tests as opposed to a single. And so when I was talking to because this question came up a lot, it wasn't just one person. It's like, here's the flip side on the house doesn't have any of that variability. The house isn't like hiding stuff. And if you do this or that the other way, it's there if you know how to get it. Right. And
Mhm.
so for me, knowing how we know how to go in there and look at it, it's a much more valid look to say,
Yep.
is it here? And if it is, then we go. So that's always been my answer. Like when I started getting these on the front end. So, and it sounds like we're in
Yeah.
a too.
Yeah. Yeah. Because the body testing is you have to understand what question it's answering. It
Mhm.
isn't, am I sick from mold or not? Am I sick from mold right now? Am I exposed right now? And that takes a very specific set of things. And even those are not 100%. So, yeah. But it's a lot easier to go into a house and cut out a sample than to go into a nose and cut out a sample and see,
It's
you know?
fair. Yeah.
Yeah.
Let's not cut someone's nose off. Um, okay. Well, this
And
was really awesome.
I wanted to let people know because we just talked about nose. There's a lot you can do to start treating your nose, by the way. I have a handout called Nasal Options if they want to get it. And I'm offering monthly masterclasses where I do a deep dive on all of these topics. So we did a deep dive on oxalates. We did a deep dive on
Oh,
salicylate sensitivity. We did a deep dive on actinomycetes, on endotoxins. We're doing binders next. We have nasal is coming up, antifungals. How do you do this? And they're all meant to the public. You get to engage with me. I do a little bit of teaching, and then we have group stuff. So I just want people to know there are places to get this deep dive information. And if you have one of those like very specific questions, we're going to cover it. Yeah.
can I just like throw something out here? First off, that is awesome. Number one, which I'm sure is the feedback you've probably been getting from people.
We're having a lot of fun. Yeah.
Yeah,
I mean, fun, no one wants to have to be in
yeah.
that.
Yeah. So I feel like most people who are listening to this probably know who you are, but for those people that don't, Dr. Jill literally trains thousands of other doctors to know how to do what she's talking about, right?
Mhm.
So like, it's not just, oh, I'm out here and I've been doing it. It's like synthesizing all of that and being able to distribute it to others so then they can execute on the same thing. The knowledge base that's sitting here is insane. And so to like have access to like a monthly masterclass that deep dives in on stuff like this is
Yeah.
it's freaking awesome, by the way. And like anyone who's listening to this, like if you want me to figure out how to like get people into that thing for you, I'll do it because I know what I know about you and I know all the conversations we've had and I've even been in the group before and talked and like all this stuff. And so that's like really, really valuable. And especially when you're trying to like navigate this thing and you don't necessarily have the right doctor, or you don't feel comfortable with the doctor you have, or you're getting the feedback that you're like, this doesn't feel right. Like, and you're then doing the deep dive, trying to search all the things. And there's like 95% wrong information out there. And how do you sift through all of it? And
There's a lot of that.
it's a lot. It's a lot. So that's cool. I'm going to make sure we get out whatever you need for me to like put out to like we'll get that. I'll stick it in show notes. I'll send it out other places too. It's fine. So
Cool.
just so everyone knows, like you should, whatever she's doing, you should listen is what I'm saying.
Thanks, Brian.
No, you're welcome. All right. Well, I think we're good for this time. I feel like, dude, this was a really tight and like packed, like awesome episode.
Yeah. Yeah. So just think of it like cigarettes.
Yeah. Think of it like cigarettes. There it is.
Yeah.
I'm going to probably steal that at some point.
Take it.
I'll credit you.
But I mean, that's it always breaks my heart when people are like, yeah, well, I haven't quit yet, so I'm a failure. And I was like, ooh, wait a minute. You're not seeing all the progress and, you need stars all over your forehead right now for all that you've done. And so that's the thing with mold, like just get what you can out.
Yeah.
It matters. Yeah.
All right. There we are. It matters. We'll see you on episode 250.
Okay. Sounds good.
And maybe before, I don't know. All right. We'll talk to you later.
All right. Thanks. Bye.